This shows some cortical areas that Carl's going to talk about. The ones I think you should know would be back here, 17. Oh, I'd know 45. That's Broca's speech area. 22 is Wernicke's. You already know area 4, 3, 1, and 2. Where's area 8 to be out in here somewhere. So we're going to talk a little bit about these. Carl covered them. Frontal lobe, parietal lobe, temporal lobe. This is blood supply. Don't forget, all this area right here would be middle cerebral. And then you could have the anterior cerebral, which is mostly on the medial wall, but does come out here on the lateral wall. Back here, visual cortex, especially on the medial wall, posterior cerebral. Underneath right here, this is pretty good, is posterior cerebral, a structure called the hippocampus right here, involved in memory. Here's the base of the temporal lobe. Posterior cerebral, that's kind of tricky. And on this medial wall, underneath this orbital cortex, inferior orbital cortex here, is some anterior cerebral. The rest would be middle cerebral. Again, on the medial wall, again, you can see this posterior cerebral comes down here and gets the uncus, and that usually designates the location of the amygdala, which we'll learn about later. Don't forget, posterior cerebral gets back here in this visual cortex. Here's that calcarine fissure right here, or the calcarine sulcus. Big anterior cerebral here, so don't forget, it's going to get the medial wall, it's going to get the leg representation of motor and sensory cortex, and it's going to get supplementary motor cortex here, supplementary motor area, in which the whole body is mapped for planning. Internal capsule, I can't tell you how important this is. This is a horizontal view, you got to know this. We already talked about the medial geniculate and the sublenticular limb. Here's the optic radiations, or retrolenticular. Remember, here's a lenticular nucleus. So it's retro behind it, sub underneath it. Then we have the posterior limb, by far the most popular, and the anterior limb in this little ganu area right here. Remember, caudate and thalamus are medial to the internal capsule. Lenticular nucleus is lateral. So the most important ones would be these cortical bulbars right here in the ganu, and you've got your little cortical spinals right here. All these stippled axons, stippled right here, are fibers from the cortex, like the pulvinar, VPL, VPM, that are heading up to cortex, and also some fibers coming down to the thalamus called corticothalamics. We go up here into the anterior limb, it's a little different. Right in here we have, again, fibers from the thalamus going up to the cortex, thalamocorticals. And then on each side we've got some corticothalamic fibers, and don't forget these cortical pontines. Pretty important that they lie in the anterior limb of the internal capsule. Blood supply, Carl loves this. Okay, here's your posterior limb of the internal capsule right here. All right, the dorsal part is going to get its innervation from these lateral striates. These are also called lenticulostriates, arteries of stroke. Okay, but now think about fibers coursing through here. If you lose this vascular input, you're going to lose those cortical spinal fibers if you have a lesion of the lateral striates. But don't forget this poor little anterior choroidal here coming off the internal carotid. It comes up in here and also gets the more ventral part of the internal capsule. So, you know, this is like double jeopardy here. You could lose this and interrupt those cortical spinals, or lose these lateral striates and lose these cortical spinals. So this is really important that you understand the blood supply of the internal capsule, especially this posterior limb. Now the anterior limb is supplied by the medial striates, which is a branch of the anterior cerebral. And another little trick is that some people think that the ganu of the internal capsule is supplied by a direct pathway from the internal carotid. Now Carl also talked about some of the association fibers in the cerebral cortex, and we can look at some of those. The biggest one is this superior longitudinal fasciculus, and you can kind of tell that it's connecting occipital and parietal and frontal areas here. Okay, this cingulum actually is a fiber bundle that runs in the cingulate gyrus. All right, and we'll talk about that in the next module more. This uncinate fasciculus, you can see, is connecting the temporal lobe with the frontal lobe, and this inferior longitudinal fasciculus kind of connecting temporal with occipital. Don't confuse this uncinate fasciculus or fascicle with the arcuate fasciculus, which I'll talk about later. This is uncinate. Don't confuse it with the arcuate. Broca's speech area. We're going to hear a lot about that, area 45. This is a speech area that probably the first one ever described. It's in the left hemisphere. Speech is more in is primarily in the left hemisphere. This would be, again, like I said, area 45 would be supplied by the middle cerebral artery. Then we have Wernicke's area. Most of this I would just call area 22. This is also supplied by the middle cerebral artery, and I'll talk more about these in a minute. Broca's speech area. Now, when you have a lesion in Broca's speech area, the person has a very hard time, getting the words out. The grammar is very restricted. He is very embarrassed by his problem. It's called a non-fluent or expressive aphasia. So Broca's, person's very awkward, very telegraphic speech, very hard to get it out. He can still comprehend because Wernicke's is okay. But down here, this is really, he's aware of his deficit, and he usually has a hemiplegia. The reason is because Broca's speech area is just rostral to the motor strip. So in a patient which has a stroke on the left side, left Broca's speech area, or the left motor strip, you're going to have a lot more problems with speech than if you have something on the right. So if you see people who have hemiparesis of the right side, there's a likely chance they're going to have a Broca's non-fluent aphasia. Now, when we move to area 22 further back, again, this is supplied by the middle cerebral. But now these people just talk like crazy. They go on and on and on. And they're talking away, and they're not embarrassed. But most of the time, they don't know really what they're saying. And they say a lot of really funny things. They're very fluent. They have these things called paraphasias. Usually, they're called a literal paraphasia would be something when somebody says something hike instead of pike. And then you have the semantic paraphasia where people will say, instead of a teacher, they'll say boss, or instead of teacher, they'll say something like laser pointer. So you should know the differences between a Broca's aphasia and a Wernicke's aphasia. The hemiplegia is rare because it's so far back in the parietal lobe, it's not near the motor strip. Again, they're really not aware of it, and I think that's the most important thing. You heard about apraxias, and I talked a little bit about apraxias when we were talking about supplementary motor area and premotor areas. And apraxia is just an inability to do a motor performance without any paralysis. If you test these people, you do a Babinski on them or anything like that, they're going to be normal. They just can't get the motor programs going. And Dr. Woodard talked about an ideational and an ideomotor. And the best example of the ideational, it would be the case where the fellow is going to use his comb to brush his teeth or his toothbrush to eat his mashed potatoes. The idea is wrong. You're using the wrong tool. I always usually think of ideational, use the wrong tool. Now the ideas, I always think about the ideas are further away from the motor strip, okay? The planning, so I think about ideational, I think about lesions far away from the motor strip out here, and it's usually on the left side here in the temporal parietal junction. Now when I compare it with ideomotor, I usually think about motor movements, sequencing of motor movements, so I think about somebody who can't get the sequence of putting the key in the door. They might turn the key before they put it in. Now, the term motor here contrasts with ideation or idea, and so when I think motor, I think closer to the motor strip. So I can always remember this because the lesion is going to be on the left side. Parietal lobe, fine, but this is the key here, supplementary motor cortex. So this is how I remember the difference between ideational and ideomotor, especially where the lesions are. Plasticity, what can you say? Dan gave a nice lecture, it was kind of brief. I guess you should understand the definition, the ability to change, okay? He says here, the brain is not hardwired, okay? It undergoes considerable modification. And I think it used to be thought that most modification would occur during childhood, like when we're very young, but they're finding out more and more that these changes can occur in the adult. I show this because I want you to know that as far as the development of the visual system, it's very sensitive to deprivation and to plasticity all around 2 years of age, although it goes around till 6 or something, right 2 to 3. And you should know this. Now the other thing I want you to know, this is just not a visual critical period, that there are critical periods for auditory too, and it's probably pretty comparable. But the visual critical periods have received a lot more study. But you should know that there are also critical periods for audition, and you should know this 2 to 3 year old period right here. Very important. Summary of developmental plasticity. Sensory systems are immature at birth. I think everybody understands that. Normal postnatal development depends on normal sensory experience, okay? For things to develop correctly, you've got to have sensory experience. You know, if you patch an eye, you're going to have to be very careful about that eye getting its normal circuitry wired up because it's not receiving its normal sensory experience. And then sensory deprivation or abnormal sensory experience during this critical period, early, first 2 to 3 years. If you don't correct it, you're going to have all kinds of sensory deficits. So this is a key, 2 to 3 years. Now, a friend of mine, John Koss, did some interesting experiments. You know about the postcentral gyrus here. And he went into postcentral gyrus, and you can see he mapped the digits and the trunk and things like this. You already know about the homunculus, okay? So this is just the homunculus laid out in this area. And what he did was, you can see digit 1, 2, 3, 4, 5, went out there, and if they would like do something to digit 3, if you cut off digit 3 and went back into cortex here and mapped, stuck a little electrode in here and stimulated a digit, you could find, they found out that where digit 3 used to be, digit 2 expanded into, and so did digit 4. So this was in an adult monkey. Now don't forget the other experiment that he did. He went in here and took out, he went in here and just obliterated D2 in cortex. But now where do you think digit 2 projected to if it didn't have this cortex? Well, it probably went into D1 and D3. So you can do 2 sets of experiments to show this plasticity. But I thought I could go through here and ask you some questions. And I'm not going to tell you the answers. You can ask me in class. But I'm going to ask you a few questions here, and this will give you a feel for how you're doing in this tape or even in this course. So I'll go through these pretty slowly if I can find my questions, but I'll just do it cold. What would happen if I stimulated this nucleus at the tip of the pointer? What would happen if I stimulated this nucleus at the tip of the pointer? Right there, right there. Okay, what would happen if I stimulated that? Okay. Next question is, what would the name of the clinical deficit be with a lesion right here where I'm making it right here? What would be the name of the deficit? And would you have a relative afferent pupillary defect right here? The next question is, what part of the internal capsule do fibers emanating from this nucleus use? How do these cells send their axons to cortex? And what number or numbers is the cortical area where these cells project? So how they get there, and what are the cortical numbers of those areas? Now, next one is, what is the deep nucleus associated with this area of the cerebellum? Next one is, tell me what fibers are coursing right in this area of this structure. And tell me whether your deficit would be contra or ipsi for each one of the nuclei involved. On this one, I want you to tell me what this artery is right here. What is this artery right here? Number 7. Number 7. Tell me what that is. It should be on the tip of your tongue. On this one right here, I want you to tell me the blood supply to, let's see, this area right here. What's the blood supply to this area right here? What's the blood supply? to this area right here. Okay, the next one, what is this nucleus right here? I'd like you to identify this nucleus right here because of something else in this slide that certainly tells you what this nucleus is right here. Okay, right here. Now I want you to tell me what the blood supply is to this area of the retina. Tell me what the blood supply is to this area of the retina. Now I want you to tell me what area of cortex do these cells project to? What area of cortex do these cells project to? And how do they get there? Through what limb of the internal capsule? So where do they go and what limb? The next one is I want you to tell me whether or not this is showing glaucoma or age-related macular degeneration. Or, since it's already labeled here, which eye is this? Which eye is this? In this particular case, I want you to tell me which window is moving the fluid in this scala. Which window is moving the fluid in this scala? This particular case, I want you to tell me whether or not this patient could have had a hole in his or her tympanic membrane. Do you think this patient had a hole in their tympanic membrane? This particular case right here, I want you to tell me whether this is the fornix or this is the fornix. The second question is, I want you to tell me whether or not this person would have, with a lesion here, a relative afferent pupillary defect. In this case right here, I want to go up in here, right in here, I want to make a lesion right here, and I want you to tell me whether or not the person would know they had a language problem, a speaking problem. Would they know it, or would they just be talking 20 miles a minute? Here's the lesion right up in here. I want you to look for the next one, the lateral superior eyelid, right here. I want you to tell me whether cells in here are sensitive to high or low frequency sounds for sound localization. High or low frequency for this LSO. And the last thing I want to do is go forward here and talk about something that I forgot. I want to talk a little bit about thalamic syndrome. And I'm not sure this is a good one, but if we had a lesion in here, in this area, in the thalamus, if we got VA and VL, we certainly would have problems with our motor systems. If we had the lesion involved VA, VL, we could have any kind of deficit associated with cerebellum or basal ganglia. Now, if the lesion was a little further back, and got VPM and VPL and things like that, you would have something called hemi-anesthesia. So think about VPL and VPM, even though it's not at this level, VPM and VPL would be wiped out, and you'd have a hemi-anesthesia, all right? You wouldn't have any sensation coming through there from the contralateral side. Now, later on, you're going to have a hyperalgesia. For some reason, you touch some part of your body, and it hurts like crazy, hyperalgesia. Now, if we're back far enough to damage the lateral geniculate body, we're going to have a contralateral homonymous hemianopsia. And I think it would be good to know the artery that goes in here. It would be the thalamo-perforating artery, which used to be called the thalamo-geniculate artery, and it's a branch of the posterior cerebral. So I hope this review has helped you. Hopefully you're going to look at this before Sunday night. But I've reviewed, like I said earlier, maybe 80 to 90% of the material on the exam. And I hope if there are any glitches in there, it doesn't bother you too much. I've probably made a few mistakes, but I hope you're at the level that you'll be able to correct them. So thank you very much.